So I'm going to actually talk about the pre-hospital aspect of things in a major trauma or a country that has a pretty well-developed trauma system. So it's like Morse code going on with this thing. That's okay, is it? I think is it because beside one another?
It's your heart rate.
Yeah. I do tactical breathing, so I'm fine. Yeah. Move it over here. I don't mind. That's okay. I'll just move it over here, maybe. So look, in Australia, obviously geography is a big issue. So they kind of really realised years ago that we need to develop an advanced pre-hospital system to meet the trauma patients' needs. They sometimes can't all get to a trauma centre in the appropriate time. So essentially, we in the aeromedical world are provide a mantle of safety to these patients. So we are staffed by a physician paramedic model. So we have either consultants like myself who are from anaesthesia, intensive care, and emergency medicine with specialist training in this area, or senior registrars in that area, and critical care paramedics who are extremely well trained, who also do abseiling, canyoning, mountaineering, ECMO, all that stuff. So it's all singing, all dancing. So our service is set up to be a primary pre-hospital trauma response and inter-hospital critical care outreach. All right, so obviously medicine is becoming quite personalised nowadays. We're unravelling DNA, we're doing DNA sequencing, we're targeting how to treat your illness or predict your risk of getting sick, and medicine's coming along a long way. Having said that, there's always a challenge with trauma, and the main challenge with trauma is that it still exists. It can be hard to prevent and it's hard to treat. But having said that, trauma does lead to innovation, and innovation is rarely preceded by excellence. So through the pressure of the challenge of trauma, we find that we have led to being innovators, and it also leads to high performance teams in pre-hospital care, and that leads to excellence, and our patients love excellence. We love excellence, and they in particular. But the challenge in trauma care is the same now that it has been for 50 years, for 500 years, and that is to try and stop the patient from dying. It's that simplistic. It's not that complicated. We're just trying to stop the patient from dying and save their life. So it is a challenging aspect. Trauma is actually a public health epidemic, and you could argue it's a neglected public health epidemic. In the UK alone, the direct healthcare costs of trauma are between 3.5 and 4 billion per annum. And it's the biggest killer of people under 40. So the future of your country is, this is the illness that kills the most people. There are three things, however, that we're very sure about in trauma. One is it is an epidemic, it is a major problem. This is from the WHO. So you can see there that injury alone accounts for more than 1.5 times the deaths related to HIV, AIDS, TB and malaria combined. So it does cause a lot of illness and death. Kinetic energy, the laws of physics, we can't change those. People are consistently hit by big things, or run over by big things, or they're hit by fast things. So we can't change the laws of physics. And unlike in the movies, we're not going to develop an exoskeleton anytime soon to combat this problem. So obviously the challenge in trauma, we often hear about the chain of survival and the trauma chain of survival and linking up the system. So the problem with that model though is that sometimes the person in the first link has no idea what's going on in the third link. It's too linear. Or the third link breaks and the person in the first link is unaware that the link is broken. So we need to think about trauma in a slightly different way, I think. And I think the way we should think of it and the way it occurs, I think, in our system is what I call a ripple effect. So when the patient gets injured, instead of there being singular chain-like models going on, there's a whole system that gets turned on around the patient. It's smooth, it's efficient, it's guaranteed to occur. But above all, the patient is at the center of that system. So what about trauma systems? Do trauma systems work? Well, across the water in England, literally, they did not develop a proper trauma system until 2012. This here is before all the system developed, odds ratio or comparative survival. That's obviously the benchmark was, 1. And then they've improved the survival over 3 years to 1.3. So there's a 30% rise in trauma deaths, or improvement in trauma deaths over 3 years. So literally by introducing a system, in 3 years they save 30% more lives, which is pretty good outcomes. In Victoria, in Australia, again, with development of a trauma system, they decreased the deaths here over a very rapid period of time. And you know, in this country, there are a lot of experts and people, both pre-hospital and in-hospital, that will be very good at managing trauma in a system. So it wouldn't take much in this country, once a trauma system is put in place, to save lives. You'd find the same effect. But I'm not going to go through a load of stats and graphs and boring stuff like that, because you can read those articles yourselves, more than capable of doing that. What I'm going to do is talk about a patient. And it's interesting how trauma patients' journeys do define the system. They're a barometer on the system, and they can help develop the system. So this is a guy called John, and he's a 56-year-old chap. He was driving, or his mother, who's 85, was driving a car in a rural setting way outside Sydney at 100 kilometres an hour. They left the road and hit a tree. So those of you who've been to Australia would have seen the trees in Australia. Literally, you could hit them with a 20-ton truck and a leaf won't fall off these trees. They're like really hard trees, like most trees. Now you can see this is the passenger side. He was in the passenger side in here, and he was trapped for 90 minutes, his knees pushed up against his chest, and his mother actually got out of the car and was wandering around. Okay, so this accident occurred here. So it occurred 15 kilometres east of a local hospital, so a rural hospital. That would be staffed by a GP. It occurred 100 kilometres west of a regional trauma centre. Now near the regional trauma centre is a helicopter base, or HEMS base, and it was 400 kilometres west of the major trauma centre. So if you think of those distances, they're quite large distances. Now sitting and supervising this whole system is the Aeromedical Control Centre. And this single central group, which is part of the ambulance service, looks after all the aeromedical assets in the state. And inside that is the Rapid Launch Trauma Coordinator. So the Rapid Launch Trauma Coordinator's job is to look through the system or calls as they come through and look for a job that will be appropriate for a helicopter response. Now they do this by either calling back the person who called 000, or they call the paramedics at the scene and say, can you give me a mist or a handover as to how badly injured this person is? Or based on certain mechanistic criteria, such as gunshot wound or high fall, they'll literally launch a helicopter. So this is what happened with this case. This helicopter is launched to the scene. A lot of things in aeromedical are around operating procedures and workflow. And in fact, years ago, the hospital would dictate how the pre-hospital world works, but actually, increasingly, the pre-hospital world is starting to influence change in the hospital and how it does, how its business is done. So Nathan and Claire, the paramedic and doctor, turn up to the scene. Now you can imagine the scenes are often sometimes quite emotive. They're quite difficult. There's bad weather, low light, ambient noise, all that kind of stuff. So we developed this workflow document or procedure, which would be similar to how a trauma resus room should work. So literally, you make sure you come out of the helicopter, all your gear, scene safety, you've got your blood esky with you, your ultrasound, communicate with the crew on scene. Then the paramedic does simultaneous logistical setup, gets IO or IV access, make sure the pelvic binder is on, etc. Delegate some of those if you can. And the doctor cuts the clothes off, gives analgesia or sedation if required, and basically then they come together. And they establish their workspace or where they're going to do their procedures if they were required. So after the handover from the paramedics on the scene was in a rural setting, remember, was they had decompressed the patient's left side of his chest. He had obviously bilateral chest injuries. They put a pelvic binder on. They'd given 3 litres of fluid. They don't carry blood on the road vehicles. And they had given them some ketamine and morphine for extrication. Often these patients need something stronger than morphine to get them out of the car. So they'd done a very good job. And these are the vitals as the HEMS team assessed. So this patient is extremely unwell, as you can imagine. So SATs at 90% on oxygen, bilateral chest fractures, respiratory rate of 38, blood pressure 60, pulse rate 140. GCS of 12 because of the ketamine, obvious abdominal injury, pelvic injury, and a femur fracture. So in a lot of settings, this patient would die, and they're quite far from a trauma centre. So this patient is big sick. So they had established their plan. Their plan was to preload this patient with blood. If you give a patient in that condition an RSI, or rapid sequence induction, and intubate them, you can often kill them by doing that. So we carried 3 units of blood cells. They gave them the blood. They got the blood in fairly quick. They didn't warm that blood at that point, and they proceeded to a needle decompression just prior to the rapid sequence induction. I'll come back to the pre-hospital massive transfusion protocol activation. That was activated, and that's a new process. They did the RSI, then they did what we call definitive thoracostomy. So these are actual surgical incisions to let the air out of the lung and relieve a pneumothorax. Both lungs were down. He was given tranexamic acid. His fracture was reduced, and he was prepared to be put into the helicopter. Now, the pre-hospital MTP activation occurred prior to all these procedures being done. Okay, this is another little thing we do before we head into the helicopter. It takes literally 30 seconds. An analogy in the hospital would be before you take a trauma patient to the CT scanner. And this is something you would go, just an aid memoir that you quickly run through before you go into the machine. The challenging environment of a helicopter means that you want to make sure all your ducks in a row before you get into the helicopter. You can imagine, even if you haven't worked in one, if you've got a helmet on, you're strapped in, you've got a life jacket on, you've got gloves on, it's very hard to treat a patient as you're flying. So just go through things from A, B, C, D, and E, and then important stuff like family and friends, phone numbers, and then the hospital being warned. So have you got theatre ready if required? Have you told the angio suite? And we call these heroic things. Do you need a neurosurgeon ready? Okay, so the Aeromedical Control Centre, we called back to the Aeromedical Control Centre and said we need to activate the pre-hospital MTP. So this is a process that developed recently, and inside this operations centre they have a live update on where the blood products are at any one time. This is a collegiate kind of process between the haematologists, one of the haematologists in a regional centre and the ambulance service. So immediately the police bring out 4 units of red blood cells, which is what they have, out to the helicopter, and they proceeded to continue to transfuse this patient. They got in the helicopter and off they went. They had to make a decision: do I fly to the regional trauma centre, which would have surgeons that can do trauma laparotomy? They would have interventional radiology and intensive care, but there was concern about cardiothoracic injuries and pelvic trauma, which this centre can't look after. So this is a long flight back. This is an EC-145, so they have to do a quick refuel. And again, they brought out cryo and FFP that were brought with the patient. And all these products are warmed in flight. En route back to the major centre, they did an abdominal ultrasound, which is equivocal, but there's constant communication going on. So unlike a linear thing, there's a constant communication going in a circle around the patient. So they warned the major trauma centre that they were coming, and the decision was made, given he responded to products, was to meet in the ED. If they were too unstable, they would meet in the IR suite or the operating room, depending. So the hospital MTP was activated, and the code crimson option was activated. So that's another option whereby a surgeon, anaesthetist, and theatre are actually made ready. All the trauma centre helipads in Australia are on the roof. And it can sometimes seem counterintuitive. If you've got a shocked patient, you've got a positive fast scan, so you've got positive for free fluid or bleeding in the abdomen, and you come down from the roof and you go down 10 floors to ED, and they could die in the lift on the way down, and then you go back upstairs to the operating room. So we, about 2 years ago, changed that system. The ED resuscitation has already occurred by the time they get to the hospital. Now these are his vitals and blood gas on arrival. So if you think about his vitals and what they were like before the intervention by the team, and if you look at this gas now, pretty reasonable. So now you've got SATs normal blood pressure. His temperature is 37.7, which is a good achievement for someone who's been in a helicopter at altitude, and he's got essentially a normal pH. and a lactate at 2.4. So this patient essentially had ongoing definitive resuscitation or ongoing management of bleeding to a point. So on arrival, his fibrinogen level was 3.0. Generally in trauma, we like to keep fibrinogen above 2.5. Platelets were 109. He had no platelets pre-hospital. Hemoglobin 138 and had a calcium of 2.1, INR 1.2. This is his chest X-ray. It doesn't come out that well on the screen, but he's obviously been intubated. These are where the dwell cats are. I've got a whole series of X-rays showing how difficult it is to actually locate the landmark and put these needles in. They generally are temporizing only. They don't work for too long. So we generally will only use this in extremis, you know, to buy a couple of minutes time before we do a thoracostomy. This is a CT scan, so you can see the patient does have some free fluid around the liver, but there's obviously something going on up here, and that he had a splenic injury as well. So actually he had a diaphragmatic rupture, and this would have been beyond the capability of that regional centre. It's quite complex surgery. He had a frontal contusion as well, bilateral rib fractures, bilateral pulmonary contusions, femur fracture, and he spent a week ventilated and then was extubated, did okay, and was sent back to the regional hospital for rehab. So one of the other important things about the trauma system in Australia is the trauma centres are geared up for the acute phase, but then once that acute phase is over, they go back to the regional centre. They don't stay there. Well, what about his mother? Now, she was actually walking around at the scene, and during this whole setup, they were asked to. She started deteriorating, and her blood pressure dropped to 80, and the team were asked to go and have a look at her as well. And she had a big, massive, expanding abdominal wall hematoma. So obviously, they're going to be looking after one patient and bringing them back in that helicopter. In the bigger helicopters, we can carry two, but in this one, we can carry one. And their hands are quite full. So again, they're onto our medical operations centre, and they launched the night helicopter medical team by road to meet an ambulance by road. So they rendezvoused and brought them back to the regional centre, where they underwent embolization of an inferior epigastric artery bleed, and she went home 3 days later. So, are there any guidelines on interventions in these kind of this care package that we provide to patients? Well, the National Institute for Health and Care Excellence in the UK came out with a document on trauma care about 2 years ago, which defines what a trauma system should be able to provide. And from the pre-hospital point of view, rapid sequence induction or giving someone an anaesthetic is the standard to maintain airway and ventilation in someone who needs it. The rapid sequence induction should be done within 45 minutes from the call. That's quite challenging in Australia. And you should perform an abdominal ultrasound to augment clinical assessment. Use open thoracostomy instead of needle where you can, and use blood products. We do not give patients in shock crystalloid. We've added a few other layers in Sydney beyond this, so we put KPIs on ourselves, like intubating the patient within 15 minutes of arrival. The more attempts you have to intubate someone, the more hypoxic they get or hypotensive they get. Even for a short period of time, that's really bad in head trauma. So we try and aim for a first pass success rate or first intubation success rate of 90%, over 90%, which we achieve. We obviously want to control CO2. And then I spoke about the Code Crimson model and the pre-hospital MTP. We also have put in, train our doctors and paramedics to perform as a team and perform life and limb-saving procedures. So we will perform resuscitative thoracotomy pre-hospital in patients with penetrating trauma who arrest. So I think what we tried to eke out over the last few years, I think the challenge in trauma and the geographical challenge has led us to try and eke out small little gains for the patient's trauma journey. And they might seem like minor little gains, but over time you end up with a big marginal gain. By the same token, if you are in a system that doesn't constantly evolve and adapt and change and try and develop, over time you actually become ambivalent and end up actually declining, and you won't even notice that you're declining. So I'll talk very briefly about the training and how do you train someone to, now if I'm going too long, David, just stop me, okay? So this is Claire, this is the doctor that was involved. So what we do is we train our doctors and paramedics to come into our system to really control these areas of these domains, their self, their team, the environment, and the patient. And we kind of we set up our training around that. Our induction program that we run for our doctors and paramedics is 3 weeks, so it's quite a long induction, it's intensive. It starts from deliberate practice simulations like this to what we call fully immersive stress inoculation, so proper, non-pausing, full bore training and exposure. We do quite active debrief sessions, and then we will do realistic simulations. So in this scenario here, the team or group is about 10 in this group. We have the doctor and paramedic in the helicopter. We've simulated the noise of a helicopter, and we've got the team watching by video feed. If they were all standing in the doorway looking in the window, it would just be too unrealistic. If you're flying in a helicopter and someone's looking in the window, that's not good. You should have checked them before, although there is room to stand there, but yeah, that wouldn't be good. Now, I didn't connect this for volume, but what's going on here is this is a mannequin. This is an eye simulate, creates noises and beeps, and we've simulated a high airway pressure alarm. And what Claire and our paramedic are going through here are emergency action cards. So we've come up with action cards for high risk things that occur, such as high airway pressure, hypotension, hypoxia, high carbon dioxide, those kind of things. And there's a proviso at the top of them, where you actually state the end tidal CO2 is high, can you help me troubleshoot? And we're trying to maintain that loop closure. So really what we have found from an aeromedical point of view is we have adapted the system to meet our geographical challenges. I would argue in that many parts of Ireland, the same geographical challenges to getting a patient to a trauma centre or definitive care is the same. We've had to provide advanced pre-hospital interventions, including blood products, to keep these patients alive until they get to definitive care. And then we found that by creating a high-performance team, we can drive the system from outside in. So this is what the pre-hospital MTP poster looks like, and essentially you call the retrieval consultant, state retrieval consultant, as soon as possible. So in the Aeromedical Operations Centre sits someone like me who supervises the whole state, so an actual physician from intensive care, emergency medicine background. That's the pre-hospital code crimson. So we've been doing this anecdotally with the trauma centres for years. We started using the phrase. The trauma centres going, what are you talking about? And we would say, we need to go to the operating room. And bit by bit we got buy-in. And then finally the Institute of Trauma Injury Management, which is the state body for trauma, adapted this recently. And this is now essentially a procedure, an accepted procedure. So while the challenges do exist in trauma care and trying to keep trauma patients alive, the challenge can drive innovation. It can develop your system into high-performance teams. I don't think we should be ambivalent about trauma. It's a really big deal, but it does lead to excellence and improved outcomes. This is John, 3 weeks after his trauma, just saying thanks, but it won't play. But I'll leave it there. Thank you very much.
Thanks, Breen. We've got a bit of time for any questions, if anyone would like to ask Breen a question. I might just kick off. Obviously, Australia is a huge country by any standards. You don't see the maps interposed of what the geography of Ireland or Britain will be in that. We're tiny by comparison. Do we need something like this?
Yeah, I mean, I think if you're going to develop a trauma system, which obviously should be developed, then part of that is to have a joined up advanced pre-hospital system that can meet these patients' needs. So essentially all the mature trauma systems have an aeromedical or rapid responsibility. And what people sometimes ask, and they're fixated on helicopters, the helicopter is not all about just getting to a patient and flying them as quickly as possible to point A to B. It's about bringing an advanced team to that patient and providing advanced care as quickly as possible and then bringing them back to the right place. plus the communication. The communication side of it is critical. You know, if I've got a patient who's bleeding in the abdomen, they've got a positive fast scan, we need to go to the operating room. That needs to be communicated. So in terms of a system, you cannot have a mature trauma system without having an advanced pre-hospital system. It just can't exist.
Brilliant, lovely presentation on the on the protocolized and process cards that you have there. Do they extend all the way through the hospital, or do they stop after the emergency department?
So the protocolized cards in terms of, are you talking about the action cards we use? That's a good question. No, because the hospitals haven't generally developed these, but all of us work in most of the tertiary hospitals, so we're kind of creeping these in now. So a classic example is the rapid sequence induction checklist, where we use a checklist so that we don't miss anything. That has gone from the pre-hospital world into all the hospitals now. So all the emergency departments in Sydney essentially use an RSI checklist. And now they're starting to look at post-intubation checklists. So they're creeping in, and they make sense as long as they're done the right way. But if you sit here with a patient in theatre or in ICU and you see them desaturate, you might necessarily need an aid memoir. But in that environment where you're under quite a lot of pressure, there's less cues, less ability to examine. They're very important, and we found them very helpful.
The other thing I was going to ask you, Breen, anyone who's done ATLS, which hopefully isn't an oxymoron, is that trauma is a surgical disease. Has that been your experience in Australia?
No. So trauma is increasingly becoming a critical illness. You do need surgeons. Surgeons are critical to a trauma system. In New South Wales, the trauma laparotomy rate for major trauma is about 3.5%. Craniotomy rate is about 5%, and thoracotomy rate is about 0.6%. So in terms of life-saving surgical procedures, they're not as common. Radiology is increasingly being used, but when you've got a very severe trauma patient, the rates of laparotomy, craniotomy, thoracotomy rise. So surgeons are critical to stopping bleeding. In the end, if someone's bleeding to death, they need a surgeon. But there's less boxed off ownership that this is a surgical disease. The surgeons don't think in that way. It's more of a joined up collegiate kind of system between surgery, ED, and intensive care and anaesthesia. To the point that if we do a code crimson to theatre, often the helicopter doctor or the ED trauma team leader comes into the theatre and is running the overall team while the surgeons operating the anaesthetist is trying to manage the anaesthesia.
Brian, just want to get your view on sort of damage limitation surgery, and one of the teams we had over from the UK spoke about they just had vascular surgeons on their trauma call initially. If the patient needs subsequently bowel surgery, that was done a couple of days later, but the initial focus was on damage limitation, and in their case it was predominantly vascular. In Australia, are the trauma surgeons, do they come from different pools of?
Yes, they come from different backgrounds, and getting proper high volume trauma exposure like in the States just doesn't occur. It's 95% blunt trauma, less surgical interventions. So the trauma laparotomy exposure is low, or open procedures. So what they've done in the UK, and Kareem Brohy has led in London, has been quite ingenious. So if you're a surgical trainee in hepatobiliary, upper GI or vascular, they're the three specialties that do trauma surgery training as well. So they tend to train in high volume centres in London. They go on to get acute jobs in their specialty, but they also look after trauma. So that's the kind of model I think that I would mimic if I had anything to do with the system here. In terms of Australia, it's a bit more disjointed than that. There are some surgeons that have a lot of trauma experience from the States. Some have done trauma fellowships in the States. There isn't true trauma fellowships in Australia. There are, but you just don't get the volume of surgery that you would want. So probably doing the UK style model is probably the way forward. So if I was a surgeon here, I would go to London, to train in one of those three areas, and then come back.
Brian, can I actually ask you, you mentioned about giving blood at the scene there. I know there's some steps to start doing that here
Yeah.
pre-hospital. How long have you guys been doing it, and is it hard to get that?
Yeah, it's funny, in Australia, there are obviously different states that have different jurisdictions and control, but in New South Wales we've been giving blood for about 20-30 years pre-hospital, and in Victoria they started about 4 or 5 years ago in a paramedic model with medical oversight, and that's been quite productive and worked as well. So it's been, you know, obviously although that stewardship around blood products, wastage, refrigeration is not an issue. We started with proper blood fridges, and I, as a doctor, was constantly logging the temperature, but now we've got the Credo military blood boxes that are very effective. Our big challenge in Australia is we don't have freeze-dried plasma, and we don't getting access to fibrinogen concentrate through CSL. It's quite difficult, but we are looking at fibrinogen particularly. Most of these patients, like this guy, would have had fibrinolysis rather than consumptive coagulopathy. So trying to get fibrinogen would be the main target rather than plasma.
Thanks, Brian. Thanks very
Okay,
much.
no, thanks for having me.
We're going to